I'm going to try to hide this. We'll see if it comes up in the other one. High floating meeting controls. Okay. Okay, I want to welcome everyone to another edition of Grand Rounds. So just a brief announcement before we get started with the introduction of Dr. Rana. We are in need of nominations, not so much external speakers. I printed out the list this morning. We have 36 nominations for external speakers and about 7 for internal speakers. And so if you have someone that you're interested in hearing about their research and what they're doing here from an internal perspective at UAB here, then please do send those my way. My email is d@uabmc.edu. If you do send those to Adam, he'll just forward those to us. So either one of us or Keisha, let us know that information and we'll add them to the list for preparation for fall's Grand Rounds. So speaking with us today is Dr. Rana, and she is an associate professor in the Department of Medicine in the Division of Infectious Diseases. She got her bachelor's at UAB, and then a medical degree also at UAB, and that was about 2003. She did internal medicine residency at Case Western, which was in Cleveland, Ohio, and did a couple of years at different times as an NIH research fellow, and then also did a fellowship in infectious diseases at Brown University. She was at Brown for about 6-7 years, and then came back to UAB in 2017 and does a lot of things here. A few of those things, including contributing, obviously, to the 1917 clinic, co-directing the Research and Informatics Service Center, and then she also does some practice of medicine at Children's Hospital as well. She chairs multiple national and international committees on HIV-related research. Primary research interests, my own synopsis of this would be, in layman's terms, finding better ways to treat HIV and get patients to buy into various treatment strategies. She's the PI on several active grants from the NIH, has about 50 publications, more in the works, written several book chapters, and her presentation today is the title is about ending the HIV epidemic in the United States. So I think we're good to go from a technical standpoint. Yeah, great. Thank you. Great.
Well, thanks to everyone for joining today, and thanks to all of you for inviting me to speak. I wasn't exactly sure, it's always about speaking to your audience, right? And so I was like, okay, what do pathologists want to know about what I do? And I know that there's, different ways of looking at the world, but I think that there's still a lot of value in understanding what we're doing on sort of my level and how it even impacts some of the things that you are seeing on your level as well. And I'll get into that in a little bit more detail. So I will be talking about primarily the work that I do. So I'll provide a little bit of an overview of the HIV epidemic here in the US, what this national, if you all are not familiar with the term ending the HIV initiative is here in the United States. And then I'm going to talk about what's going on here, what's happening in Alabama, what are the issues that we are dealing with, and how we can work together as UAB with our public health and community partners. So, when I think of pathology, this is what I think of, from I graduated from medical school 20 years ago. So I'm like, all right, path, I remember that, this is what I do. So maybe we do that, you take large tissue or small tissue, you make it smaller and smaller and smaller, and you look at it really on that, microscopic level. And maybe I do that too, but, just a different scale. So we're doing more population health. We're taking a step back from our communities and seeing what are the interventions that we can do that more will broadly impact global health, and really examining sort of what that is. So just to give you a little kind of update with regards to where we are with HIV. So it's been more than 40 years now since the first identified really cases of HIV in the early 80s. And it is now a chronic illness. So there's excellent, well-tolerated therapy for HIV, as simple as 1 pill once a day. I have 2 of the 1 pill once a day regimens that we commonly use for our patients. And in fact, as of last year, there's even injectable medication. So similarly with birth control or mental health treatment, where people can take medications every month or every other month rather than having to take it every day. And then we also have data that showed that starting everybody on therapy as soon as possible was excellent for a number of reasons. But the first one is, how does it impact an individual's own health? So HIV, as you know, attacks the immune system, reduces CD4 counts and our cell-mediated immunity. And in a large study which looked at immediate initiation, even at higher CD4 counts versus deferred initiation, waiting for their CD4 T cells to drop below 350, found a significant reduction in both death or serious, both AIDS-related and non-AIDS related events in people who were started as soon as possible, as soon as they were diagnosed. So that was the START study in 2015. Then we also have the public health impact. So people who are on medication and are taking it regularly and have their virus under control will not transmit the virus. And this is from a large study from the HIV Prevention Trials Network, done both nationally and internationally, that had a similar setup where people were started either immediately or deferred, and then they were followed and their partners were followed with regards to acquisition of virus. And there were no cases of acquisition in people whose partner was on treatment and was virally suppressed. And there's been a number of studies really duplicating that success, and was really recognized as the breakthrough of the year by science. I mean, we knew this clinically. We see our patients, we know who their partners are and what's going on, and the ones who are virally controlled were not transmitting the virus. But we would always have to have this little caveat, right? Of, okay, you're with your partner and you're monogamous, and the chance of you, spreading this virus to your partner is close to zero. And we couldn't say zero, but now we say zero. Undetectable means untransmittable. And then we also have more prevention strategies other than condoms and treatment as prevention. We have actual medications that people can take that have been shown, when taken effectively, to prevent the spread of HIV. So Truvada, which is actually just an antiretroviral, is recommended for people who are sort of in that category of having, risky behavior, which includes sex and injection drug use. And that's a pill that was approved in 2012. Cabotegravir is an injection every other month people can take who are in those risk or perceive themselves to be in those risk categories, and is also now FDA approved and able to be used and now recommended by the WHO. Now, cost is a whole other issue, but that's sort of where we are. So we have these, great things. So HIV is not an issue anymore, right? Like, we've solved it. We know how to treat it. There doesn't need to be transmission, and we have prevention. So we're all done, right? And we are absolutely not. So there's about globally almost 40 million people living with HIV, and still about 1.5 million new diagnoses worldwide. In the US, we have about 1.2 million people living with HIV, and approximately 40,000 new diagnoses each year. And the concentration of the HIV epidemic, I don't think it'll be a surprise to anyone, is in areas where there are a lot of health disparities of many stripes. So the Southeast United States has the highest concentration of and rates of incidence of HIV, with Alabama certainly being one of them. In addition to geography, there's a disproportionate impact of the epidemic among young, gay and bisexual men, African American, and certainly people with poverty, other structural issues, and other sort of social determinants of health kind of mingling together in this way. So really it impacts a fairly vulnerable population in this way. And so how are we measuring how well we're doing with HIV? So once you're diagnosed with HIV, you've got to get linked to care, right? And then after you get linked to care, you need to get started on treatment. And once you're on treatment, you got to continue to take the treatment so you can stay virally suppressed. And so this is how we're doing in the United States. So it's estimated that 87% of people living with HIV are aware of their diagnosis. There's some fancy modeling that the CDC does with regards to timing of presentation, where it estimates how many undiagnosed people they are. So close to 90% of people we think know their diagnosis. Of those in 2019, not even 70% of them had any evidence of being in care, like even having one visit. And that was marked by all CD4s and viral loads are sent to the public health departments, mandatory lab reporting. And so that's what they're using as the marker. Now, there are people who might have gone to see a doctor, but didn't get a lab report done or a lab done. So it is potentially missing those people, but you know, in the clinical care of a person with HIV, you are getting a lab report at least once in the year. Of those, only 50% are what's called retained in care. And that's based on national guidelines that somebody who has HIV should be seen by their provider probably twice in a calendar year. And so only half of all of those 1.2 million people estimated had that, with 57% having their last viral load that was seen by the public health department as less than 200 copies, which is kind of our threshold for suppression. So that's where we are in the US with, you know, over 500,000 people not sort of gaining the benefits of excellent therapy. And how are we comparing to the rest of the world? Is everyone else in this same boat? Not exactly. So, you know, we have everywhere from like Switzerland and UK and Sweden and the Netherlands. And I was just in Australia a few months ago, 80, and actually Australia is now closer to 90% viral suppression. And then we're dead last in high income countries. And this is important because when we model as to where and with whom the new transmissions are occurring, what you can see here in the HIV transmissions chart is that the majority of new transmissions are occurring because the transmissions are occurring by people who don't know their status. So that's about 38%, but 43% of new transmissions are related to people who are aware of their status, but were not regularly in care. And so really, and then 11% again are those in care, but for whatever reason are not virally suppressed. And as we showed in the study, 51% are taking their medicine and are virally suppressed, and they're not related to any new transmissions. And so understanding the why, right? Like, why is this happening? And so taking a framework, or what we do is we take a model that looks at all of the different factors and levels that inform these outcomes. So the first one, I think, is the most obvious as clinicians. We think about the individual level factors, right? So we're talking about, you know, an individual's mental health and their substance use and what's going on with their housing status, and certainly taking into consideration social determinants of health, but you know, and where they're living, you know, like, do they live near a clinic? Do they have access to care? Then there's like the network level. What's happening in their social network? Is there high STI prevalence? Is there a different like risk group? Is there a lot of, you know, substance use going on in that population? Then we think of community level factors. You know, what is the stigma of living with HIV? What is the stigma of their vulnerable identity, whether it's, LGBTQ, whether it's their gender, whether it's their race, what is that factor? And then what are the policies that inform it? Like community level, are there needle exchange programs that are permitted? Then we talk about social and structural level factors. Are we living in areas where there's a national healthcare system, or is there Medicaid expansion? Is there access to medication? What is their sort of policies with regards to discriminatory practices? And then the broader stage is epidemic. So what is the overall prevalence of HIV, other STIs, and other issues that drive this more at that level? So understanding all of those, people will say, well, it's just a pill. Why can't they take just a pill a day? you really got to understand everything that's informing the intersections of the outcomes in this population. The other thing I think is people are people, and people change and factors change. And so engagement in care is dynamic. It's not a one-way system, right? So there are people who get diagnosed and stay in care forever. And that's by the green line here. This was a pretty elegant analysis using those mandatory CD4 viral loads that are sent to the North Carolina Health Department. And they kind of wanted to look at this, like what are the patterns of engagement in care? Then you have those people who get diagnosed and like never go in care or stay out of care, the red line all the way at the bottom. And then you have the people in between. Some stay in, some go out, and they go back in again, go back out again. And from surveillance data, you can't get a whole lot of details beyond some demographic factors. So really trying to understand the factors that form this pattern is going to be key. So as I mentioned, the rates of new diagnosis in the US are most like the heaviest in the South. And, the US accounts for 37% of the total population and over 50% of all new HIV diagnoses. And also in the South, Black and African Americans have the highest rate, followed by Hispanics. And you really see a disparity in outcomes when you start looking at racial and ethnic and certainly socioeconomic differences in the populations. So here we have the estimated HIV incidence and population among persons. So just to sort of highlight that. So Black and African Americans make up only 12% of our overall population, but 41% of all new diagnoses. Likewise for Hispanic and Latinos only make up 17% of the population, but 29%. So we are certainly seeing that disparity. And then we also see disparities in our care outcomes. So the black bar is everyone across the board in that care continuum that I'm talking about. But as you can see, younger age, so diagnosed ages 13 to 24, Black African Americans, and those who are injection drug users and male have much lower HIV, much lower poor outcomes on the care continuum compared to the whole. And there's this, I have that interesting study, it's about 10 years old now, but I think illustrates this point. So they looked at all new diagnoses nationwide and modeled them based on their sex, race, and their geographic region to see, and did a survival analysis in terms of HIV-related event or an HIV or AIDS defining event. And of all of the populations, non-white women residing in the Southern United States had the worst long-term outcomes after diagnosis. And a part of that is that there is, very fragmented healthcare delivery in the US. So HIV testing, prevention, and care, they can be done at all different places. So I work at the 1917 clinic. It's a Ryan White clinic. It's a federally funded a clinic to provide care for HIV patients. And I feel very comfortable with antiretrovirals. Of course, I can prescribe them. I, by law, cannot use that same clinic or those same funds to provide HIV prevention treatment. So I can't write for PrEP. I can't write for cabotegravir using the funds of the clinic itself. Those need to come from a separate source. And so people might have to get care, in different settings, even though the same populations are the ones that we're trying to impact. When you're talking about pregnant women, you're talking about even more fragmented care. So if I have a woman in my clinic and she becomes pregnant, well, she goes somewhere else, she goes to Children's for her, she goes to, the WIC to have her prenatal care. And then her child has to go to Children's to get HIV testing. And then she also has to make it back to see me. And at least we're at the same institution. I mean, in different cities, they have to go to all sorts of different places. And of course, the funding insurance is also very complicated. And the overall insurance coverage for people living with HIV is not terrible, but knowing that there is a federal program that helps to provide insurance for people with HIV. The overall uninsured rate in the United States is around 10%, but it's much higher in the populations that are considered at highest risk for HIV. And so when we look at health coverage of non-elderly adults by race and ethnicity, and then see the states that expanded Medicaid, you see this disparity even further highlighted. So in non-expansion states, the proportion of people who are uninsured do tend to be of racial and ethnic minorities. So what can we do? So we have the tools, like we can do this, but we need to figure out how to implement. How do we implement these very effective biomedical strategies? So we have the biomedical interventions. We need to combine them with behavioral interventions, and then also combine them with the structural interventions, particularly at the community level, to impact this epidemic. And I postulate that the only way to do it, and particularly in a state like Alabama, which is a non-Medicaid expansion state, that it is really critical to coalesce, I think, the expertise of our academic institutions, and we have our Center for AIDS Research here, with the kind of the power and the strength and the authority of the public health agencies, but alongside our community partners. So those include communities impacted by HIV, as well as community-based organizations, municipal policymakers, and care delivery organizations together. So the Ending the HIV Epidemic, A Plan for America, was released by the Department of Health and Human Services in February of 2019. And it has an extremely ambitious goal of the reduction of new infections by 90% by 2030. I mean, even 75% by 2025, which is 2 years from now. And it kind of tasks all of the different agencies of the Department of Health and Human Services. So HRSA, which funds the Ryan White clinics, the NIH, of course, the CDC, and other agencies, to all work together on these 4 pillars. So diagnose people as early as possible, treat the infection as rapidly as possible, prevent new transmissions by using pre-exposure prophylaxis or syringe service programs, and then to also do molecular cluster outbreak investigations. And so the other part of this plan is that it has geographic priorities. And so there have been 48 highest burden counties, plus DC and San Juan, identified as areas of focus for this initiative, as well as 7 states. And those 7 states are highlighted because of their significant non-urban epidemic. And Alabama is one of those 7 states that have been highlighted as the focus for this initiative. So what is going on in Alabama? So, you know, Alabama has almost, I think, a population of almost 5 million people. Median age in the state is like 40 or so. And our poverty rate is about 17%, 29% here in Birmingham. But in Alabama, we have about 16,000 people estimated to be living with HIV. And this map shows kind of where the highest prevalence, with the highest prevalence is, with the darker colored, meaning higher rates of prevalence. And so, of course, we have Birmingham and Mobile, kind of more urban centers. But then across the southeast, southwest border is this region called the Black Belt. And it is so named because of its like rich soil. It's very agricultural, and it's also very rural. And so we're not talking about really, we're not talking about tens of thousands of people there, but we are talking about for that population, very high case rates. And then when we're talking about outcomes, we're talking about fairly poor outcomes. And this is an area that experiences disparities of many stripes. We're talking poor outcomes in cardiac, cancer, metabolic outcomes as well. And so I think this map really illustrates the importance of geography in that. So as I mentioned, about 16,000 people living with HIV. We've certainly had a decrease in the amount of deaths, But I also want to point out in terms of incidence, we've been kind of stagnant with all of these interventions that I was telling you and all of these great things. Over the last few years, we've been sort of flat. And so where are we in Alabama on that care continuum? So this is what's called a diagnosis-based care continuum. This is what the Alabama Department of Public Health publishes. So what that says is, of the people who know they're aware of their diagnosis. So they're not including in the denominator people who they estimate not to be aware of their diagnosis, which they think is a little over 2,000 people. So of the people who are aware of their diagnosis, just under 60% had their last viral load as suppressed or less than 200 copies based on 2020 preliminary data. Of course, when you add the denominator of those 2,000 who aren't even aware of their diagnosis, then we drop significantly more in that setting. And the other thing to consider is how many of the people who are at risk for HIV are having access to that prevention option. So either the Truvada or Descovy, which is the pill to take daily, or the cabotegravir. And so this is a modeling analysis done by Patrick Sullivan at Emory that he created a metric called the prep to need ratio. So basically looking to see, of the people, how many people were diagnosed with HIV in this area, which he did as a state, versus how many PrEP prescriptions were written, unique PrEP prescriptions were written in that state. And so you want to have as high of a number as possible, right? So you want you want a lot of PrEP prescriptions, and you don't want to have a lot of people who have diagnosed with HIV. And Alabama was one of the worst 3 states in this model. So a very high number of people who need to be on prescriptions, but not a lot of prescriptions being written. And then when we then break that by racial and ethnic characteristics, it's even worse in that setting. So what have we been doing? You're like, all right, there's a problem. What are y'all working on? All right, we're working. So certainly want to share all of that. So about 13 years ago, a lot of this work is understanding the data. Like, we got to be as data driven as possible, obviously. And so there were a lot of silos we don't have a national healthcare system. We don't even, sometimes I can't even figure out what's going on at Children's Hospital. It's hard to have sort of like data sharing that's going on. So one of the first things we did was bring together all of the different clinics that were providing care in Birmingham, as well as the community-based organization, and then the keeper of the keys, the health department, and said, hey, can we have some process where data sharing can occur so that we can learn, okay, who's diagnosed? We know they're diagnosed, but we can't find them. Can you help us find them? Are they in care? Did they get into care? And how can we employ the support of some of these community-based organizations to help address gaps in their care, as it were. So really have that kind of health information exchange potentially setting up and making it easier for these referrals to happen. We also started coalition building. So these same individuals at Birmingham Unite then created a county coalition. So the Jefferson County HIV/AIDS Community Coalition meets regularly at the Jefferson County Health Department, includes all of these community-based organizations, as well as the UAB Center for AIDS Research. And we actually use that group to say, hey, you guys have the opportunity to apply for these public health funding announcements from the CDC to improve your testing, to improve your linkage. We can help with some technical assistance, but you all take ownership of this. So there were several grants then that were funded through the CDC, Game Changer and BCHIP, focused on that output. We also have regular meetings with all of our frontline providers, and those are not just prescribers, they include social workers and nutritionists, kind of working to serve this particular community. And we have really taken leadership on bringing together partners within the Southeast on trying to really understand the drivers of ending AIDS here in the Deep South. We have the privilege, I think, of being a fairly collegial group of people. So all of the, I mentioned the HRSA program that funds the 1917 clinic, that's known as the Ryan White Federal Program. And so that funds HIV care clinics nationally. And our state has about 9 HIV clinics that are funded by the Ryan White program. So we meet quarterly, all of the clinics. We used to meet, we now are back to meeting in person here in Birmingham, and we go over quality metrics. So how many people are you serving? How many people are on medication? What proportion of your clinic had their last viral load was suppressed, and how many of your patients had missed visit? And then it also provides this opportunity for clinics to share like best practices among each other, like they've developed new interventions or kind of going through that work. And this is like mandated by HRSA to do, and we were sort of very on board with it even before the mandate came in. But I think the very unique part about this is that it is from clinics statewide. And the stars are the physical locations of the clinics, and the circles are actually all the telehealth sites. So as you can see, do you remember I was talking about the rural parts of the state? There's not a lot of physical clinics in that place, but we try to do telehealth in that area. So with Birmingham Unite, I'll just share that, because we were able to get those collaborative grants, integrated service delivery, we can't say causation, but there was a 25% reduction in new HIV cases, just particularly in Jefferson County over that time period. So as mentioned, I do run the Ending HIV in Alabama Scientific Working Group. And so within the Centers for AIDS Research, there's core services that are provided. And a scientific working group, the purpose of it is to essentially bring people together who are interested in this particular, focus research area, and to see, how we can all work together to put in grants and publish manuscripts. And so this was kind of unique because usually it's about, I don't know, like flow cytometry, or there's like a specific focus of science. And here I'm like, well, our focus of science is how do we end the epidemic in our state? And so there was an initiative that was released by the WHO in 2015, actually, called the 90-90-90 initiative. And that was saying that we have a target goal that by 2020, that 90% of people living with HIV would know that their status. Of those, 90% would be linked to care, in care, and of those, 90% would then be virally suppressed. And that ends up being an estimate of about 73% population level viral suppression. The reason they came up with that estimate, it's catchy, but also they were trying to disrupt that stagnant rate of new infections annually, globally, that was happening. And they're like, this is what it's going to take from a population treatment as prevention level to really disrupt that and end AIDS, meaning end people presenting with low CD4 counts or opportunistic infections. So that's what we used as our framework. The scientific working group was formed in 2017 before the EHE initiative. We've now recalibrated it to more align with our national initiative, but that's how we have sort of done it. And the purpose of this group was to really bring together all of the partners that I mentioned. Academic researchers, public health, really engage public health agencies, and community partners on research focused on initiatives, implementation, mostly initiatives to end the epidemic. And so we funded a number of grantees already who are doing a variety of projects that are, again, more geared towards implementation. Dustin Long in Biostats, he's trying to understand, I mentioned that we estimated a little over 2,000 people undiagnosed. Well, that's sort of a blanket estimate from the CDC, and it's statewide. Like there's 14% of people who don't know their diagnosis in the state. Okay, well, who are they? Are we talking about young gay and bisexual men? Or are we talking about like older women? Are we talking about Jefferson County? Or are we talking about Wilcox County? And so he is using some data sets that we, as the scientific working group, helped to procure to get a little bit more granularity with regards to the undiagnosed population to help inform our testing interventions. And Samantha Hill is working on increasing the use of PrEP, pre-exposure prophylaxis, in adolescent populations. She's at Children's Hospital. And Matt Gravitt also working on innovative ways to inform people about PrEP. And Olivia Van Gerwen is understanding risk and PrEP usage among transgender women in the Southeast. So I mentioned we are the keeper in the scientific working group of some of these public health data sets. So we were able to work with both Quest and LabCorp to get results for HIV, STI, and drug screen testing data for the state of Alabama over I think 7 or 8 year period, and some geography, like we do have 5-digit zip code. And the purpose of getting those data sets is to try to triangulate some of that, where are a lot of these risk factors occurring? How can we inform our testing interventions for that as well? And so investigators will be able to have probably access to this data to help inform their own interventions that they're going to propose, particularly as it relates to testing. We'll also have data from ADPH surveillance, as well as Medicaid claims data too. And then the other thing that we're working on with the SWIG are community funding grants. So the 1917 clinic has access to funds through its pharmacy rebate program, as long as they use those funds for interventions in their population that they're treating. And so we're helping them with kind of distributing those funds, reviewing grant applications. And so the interesting thing about this is, so it is the community-based organization who puts in the grant application. Often these community-based organizations, they have a lot of great ideas and a lot of work, but they don't know how to write grants. They don't know how to do methods and evaluation. And so then we partner them with a CFAR investigator to help them with the methods and evaluation, to help them to say, okay, what are your outcomes? Let's make sure, because you got to let the funder know these are what the outcomes are. And so we've been really successful over the last few years with both these partnerships. So having the title, the collaborator, and then as well as assessing the impact. So just to highlight, I think a few of the projects, I'm okay on time, that we've been working on. So Dr. Letitia Alopre, so she's been working in that Black Belt area with a community-based organization trying to assess African-American women and their preferences for pre-exposure prophylaxis. So we talked to that, she talked to over 300 women in rural Alabama, which in and of itself, I think is quite the feat. And to try to assess through discrete choice modeling with regards to what would be some of their preferences. So most women preferred to get their PrEP at a doctor's offices or family planning, less likely to want telehealth or go to an STD clinic or even go to a pharmacy, which is interesting because there's a lot of pharmacy-based interventions to increase access to care. So it's important to sort of listen to your population. The other thing that was interesting is, what mode of medication form would they be interested in? And most were interested in either a pill or a long-acting shot. And for this community, much less interested in, say, implantable PrEP, which is being investigated, as well as vaginal ring. And Lynn Matthews, also in my division, is using that testing data, so that same public health data set that we talked about, to identify cold spots with low testing rates. And once they identify those, to then share this with the community-based organizations to say, hey, this is, you guys have a community-based testing program. These are the areas where you may be wanting to prioritize your testing. And so I've been working with Dr. Scott Beatty on an R01 looking at geographic time geographic variability in time from HIV diagnosis to viral suppression. So basically traversing that whole HIV care continuum. And we're privileged to partner with actually 3 state health departments. So Louisiana, Mississippi, and Alabama, and in their surveillance division. And really the time to viral suppression, it's kind of this really neat, like, indicator. It's the collective effectiveness of what's going on after HIV diagnosis in your community. You know, everything like from diagnosis to linkage to, you know, getting started on ART, staying on ART. And so kind of really assesses how all that's doing in an aggregate way. And what we found in prior evaluation in Alabama, that there was a lot of difference across the state. So, you know, anywhere from 5 months to 13 months in time to viral suppression, depending on your public health area. So what are the drivers of this heterogeneity? And that's what we propose to do with this grant. So we did a retrospective population-based cohort study of all persons ages 13 years and higher who are newly diagnosed in those 3 states from 2012 to 2019. I mentioned earlier that all CD4 viral loads are mandatorily reported to the health departments, and that's collected in a system called the Enhanced HIV/AIDS Reporting System, or EHARS. We helped to develop this data structure. All the analysis was done behind the curtain at the health department. So we basically, with their input, helped to develop the structure, wrote the code, and then they did the analysis. And then they send us sort of aggregate data for us to do that. And so then we use the Kaplan-Meier method to really look at the time to viral suppression by year of diagnosis. We separated it from 2012 to 2015 and 2016 to 2019 for each state. The reason for that split is 2015 is when that data about the START study and the INSIGHT study with regards to treatment for everyone is better, like don't wait. So that changed national guidelines in 2015, where we were no longer waiting. Also, that's when national guidelines changed to the use of integrase inhibitors, which is a class of HIV medication, which brings viral load down very, very quickly. Third reason we wanted to make this split was Louisiana was the only one of these 3 states to expand Medicaid, and they did that in 2016. So we wanted to see what are, were there, differences in that impact. And so we were able to include about 16,000, a little over 16,000 people from all 3 states in this analysis. The majority of people were sort of in the 25 to 44 range, with about 3/4 male sex at birth, a little bit different in each state, majority Black race, and about 50% MSM, men who have sex with men transmission, and about 1/4 having, 3/4 having non-stage 3 presentation. So stage 3 is basically presenting with either a CD4 count less than 200 or an opportunistic infection, so very advanced disease. And so this is what we found. So the dotted lines down here are the 3 states from 2012 to 2015. So yellow is Mississippi, purple is Louisiana, and red is Alabama. So this is what was happening at that time. So very prolonged time to viral suppression, with less than 40% even ever becoming virally suppressed by even 6 months out. And you see a very dramatic improvement from 2016 to 2019, with the biggest jump happening in Louisiana. And when we look at this geographically, this is what's happening by public health area in 2012 to 2015, where you have sort of, Mississippi, sort of the longest times all throughout the state, but areas of, coastal Alabama, as well as Louisiana having longer times in 2012 to 2015. And then you see significant improvement again with 2016 to 2019. And I'll be sure to point out public health area 1 in Louisiana, that's New Orleans actually. And they went from a time to viral suppression of close to 200 days to less than 70. And we think that in addition to, all of the things, treatment as prevention and integrase inhibitors and potentially Medicaid expansion, there were several clinics in that area that initiated rapid start programs for initiation of ART. So sort of as soon as they're diagnosed, they were started on medication ASAP. And they changed the structures of their clinic to accommodate for that. When we tried to look at predictors of viral suppression, again, in this area, there's only so many questions you can ask surveillance data. And so being of sort of, older age was predictive of a faster time to viral suppression, male sex at birth, white race, MSM transmission, and then also having actually advanced AIDS at presentation was predictive as well, which makes sense and has been shown previously in that most people who are presenting with advanced disease are fairly symptomatic and want to be treated. We looked also at the impact of the COVID pandemic on viral suppression in 2020. And the big takeaway from these survival curves is that consistent improvement that we were seeing every year, we didn't see it anymore in 2020. Now, a lot of that is people didn't come to clinic, people didn't get viral loads, but it'll be interesting to see sort of what this, significant improvement that we've gotten to have, how we've stagnated in that way. And I just wanted to point out, this was a presentation we just did at one of our conference in Seattle 2 weeks ago now. And this was driven by the health department. So the Louisiana Health Department reached out to us and they said, we love this data. They're using the data to help inform some of their interventions. But what is the impact? Like, they had been looking into this concept of redlining. And if you all aren't familiar, redlining is a program done by federal housing lending programs back in the 1930s, where they would go to areas and sort of determine what were likelihood of giving loans to this area, to people who lived in this area. And so you got graded whether it was excellent, definitely give loans to people who are in this area versus absolutely not. And that was the worst grade. So that's grade D. And that was known as a redlined area. And so we wanted to look to see what is the impact of sort of this very systemic, structural, racist policy from the 1930s, on care outcomes almost 100 years later. And so, so the health department was the one who asked us this. They're like, can we use your data to do this type of analysis? And so we were thrilled about that, first of all, because we think it's very intriguing. This is not a question that's been asked very much. And also, it was our health department partners who came up with the question. And so that really helps to show that collaboration and the importance of that as well. And so just to highlight, so this is New Orleans. These are the areas that were whole grade D or redlined. And we were able to do this for Shreveport and New Orleans. So those were the two areas where we have the data on what areas were redlined. And I think not surprisingly, yes, there is a difference if you were diagnosed even in between 2012 and 2019 in areas that were redlined in the 1930s. Now, of course, it wasn't just the redlining of the 1930s that did that. What are those areas? Are these the areas more likely to get flooded? Are these the areas where there still hasn't been real estate investment? All of the things that then inform social determinants of health in that area and that population. But for the Louisiana Health Department, it made them think, okay, are there ways that we need to then now adjust our implementation policies to help target some of our interventions, particularly related to social determinants of health in these areas. And then I'll end with a program that we just got funded for last year with the Mobile County Health Department. And I think this one really shows the importance of a champion. So we've been trying to work with Mobile County for many, many, many years, and I think had not really made a lot of headway in that way. I mean, it's 4 hours away. It takes a while to get there. And I think for a lot of community-based work, it's all about boots on the ground. And, do they trust you? Do they think you're what are you here for? Are you just here to get data and then leave? Or are you going to do something with us? And so this lady in the front here, Dr. Rendy Murphy, she's an epidemiologist, and she worked at the CDC for many years for the Tennessee Health Department, and then retired to Mobile, and then decided to not retire, and is now the epidemiologist with Mobile County. And she was the one who reached out to us and said, how can we work together? And that was amazing. And we're like, yes, we'll figure this out. How can we work together? So we are working with them on this project that we are calling Coastal, which I promised Coastal is somewhere in these letters. We had to pull it out in there. So it's really trying to build together a combination intervention to try to improve every step of that care continuum in Mobile County. So one of our first things that we're going to do is that same data, we're trying to find the cold spots. We're going to hone in on Mobile County and their surrounding counties to say, okay, this is where you need to do your sort of community-based HIV testing. And then the other thing is we're developing an intervention where as soon as somebody is diagnosed, there's a tool called the Prepare tool that's used by federally qualified health centers around the country that assesses social determinants of health, housing instability, food insecurity. If we could get that assessment at the time of diagnosis and then share it with the clinic as they're receiving the patient, it might help to improve linkage, and it might help with their retention and care as soon as those are offered. And then, I don't know what happened there. And then the last part is rapid initiation of antiretroviral therapy. So that's a program to improve viral suppression. Mobile County tends to have the longest time to viral suppression of all of the public health areas in our state. So implementing this in the clinics in Mobile County. And I'll end actually with I think I have a couple more slides. One is we got funded a couple of years ago for a program to improve underrepresented populations in HIV research. And so we have a program that we are working on with Birmingham City Schools, of course, UAB, both undergrad and graduate, focused on improving or connections to HIV research in that population. And then this is why we have to continue to do this, because I was on service in December, and these are some of the cases that I saw. So I saw a 34-year-old African-American male who was diagnosed 6 months prior with PJP pneumonia, CD4 of 10 and viral load of 600,000 at that time. He was discharged on trimethoprim sulfa, but he never engaged in care after his diagnosis. And then he was admitted with acute liver failure. He had MRSA endocarditis, acute necrotizing encephalitis, and he died. Then I saw a 28-year-old who was admitted to the psych ward for her acute psychotic break. She was not in care, had not been in care, and she was a victim of sex trafficking. And we had to see how we could then, engage her afterwards. I saw a 34-year-old male who was admitted to the MICU for fentanyl overdose. So he was in the MICU for overdose, not related to HIV. We were consulted because he actually ended up having secondary syphilis. He had the rash on his hands, and we found out that he was out of care for over a year. And then, also at that time facilitated disclosure of his status to his partner, who he had been with for 2 years, but had not disclosed status at that point. And then I saw another woman who was 20 years old. She actually presented in labor. She'd only had one prenatal visit in her first trimester. She was HIV negative at that time, but she presented in third trimester for UTI symptoms for a sick visit, so not a regularly scheduled visit. Those were all treated, but they didn't do a repeat HIV test. And she was certainly she was certainly high risk. And she presented 1 month later at delivery, as I mentioned, and unfortunately the infant also tested positive as well. And so, I think this just really speaks to, this is real. These are not hypothetical cases. When we're on service, we are often, seeing all of these cases. And this is not a unique, because I was on service, I saw them. This is very commonplace still. And so just wanted to highlight again, all the various projects that we're working on, trying to impact the epidemic here in Alabama. and certainly grateful for all of the community partners that we have that work with us and hopefully continue to work with us, as well as all of our great investigators at the CFAR, and then of course the 1917 clinic. That's my last slide.
Dr. Rana for a really great presentation. We well communicated. About 5 minutes for questions.
Is there any improvement in the prognosis for patients who have HIV and hematologic malignancies, especially in underprivileged population?
Yeah, that's a great question. So at a population level, yes, there is a significant improvement. Controlling somebody's virus certainly improves their outcomes in hematologic malignancies. We still see diagnosis of hematologic malignancies, but it's so low now or so much rare now. We used to employ a hem-onc doctor in our clinic because it was so common. We no longer employ a hem-onc doctor in our clinic. We refer them to Kirkland Clinic because in generally they tend to do fairly well, but it still happens. People with HIV, even with controlled virus, are at higher risk of any type of malignancy, AIDS defining or not, but not the poor outcomes that we saw previously.
Right, so line like it's funded diabetes.
Yes.
But you're not allowed to, right?
No, not in a Ryan White funded HIV clinic. I can if I was doing a PrEP clinic, so, like if Kirkland Clinic had a PrEP clinic, and they, and we do have a way to do that. But if I am in a clinic that's funded by Ryan White dollars, and the nurse is paid by Ryan White, and the staff is paid by Ryan White, then I cannot write a PrEP prescription. I cannot provide PrEP services.
Why?
Yeah, that's you should call your congressperson. It's federal law.
Is it abstinence on sex education?
No, I think so the Ryan White program is for patients living with HIV, right? It's kind of like end-stage renal disease. You get on Medicare once you're on dialysis, but Medicare will not cover uninsured people who are stage 4 kidney disease. So yeah, talk to your congressperson, because it doesn't make sense. We are the ones most comfortable with the community. We are the ones most comfortable with this population. If I could just open the door and say, hey, my patient, bring your friends, bring your, whatever, this would be the perfect place where they would hopefully feel not as stigmatized as well. But yeah, it's a big issue.
So why can't you go back to wherever else you're working? You've got all this data, and you tell them I'm going to call this prescription in.
Yeah. So start giving somebody on PrEP is not just starting the pill, right? We got to monitor them. They got to have HIV tests. They got to have labs. So they can. I'm not saying it's impossible, but you cannot use I cannot use my clinic structure to do it. Can I do anything unpaid and under the table? Of course I could, right? But there needs to be spaces. Now, what Department of Health and Human Services has said is that these patients will be seen at federally qualified health centers. So that's a different division of HRSA. That's the Bureau of Primary Clinics. And so their directive to me is to send them to a federally qualified health center, which is what we do and other clinics that can do it.
And then how do they tend to show up when you say you needed?
No,
No, they don't.
no, because they don't know those people. They don't feel comfortable. Those providers don't feel comfortable prescribing them. I mean, I'm being dogmatic in my statement, and we need to do better education on the whole, but these are missed opportunities from a very vulnerable population, right? And we can't keep missing these opportunities. Yes.
So we also work with vulnerable populations in terms of overdoses. And so it mirrors Narcan training to me in some way. So is it not safe to mobilize PrEP training or PrEP education and PrEP administration and hand out prescriptions in the same way that we do Narcan?
I think it's great, and let's talk about this. That's exactly what we're trying to do.
Told you.
Don't tell me that she.
Or,
So decentralizing, absolutely, I think, and doing it in a way that doesn't stigmatize the community where you're driving these vans is going to be key. So let's work together on that. So I think pairing that will be great, but then also learning how to do it in a non-destigmatizing way. So a catchy title that doesn't, do that. Make sure your van doesn't say, hey, drug overdose.
Always got one of those vans.
Yeah, so yes, I think.
White van, nothing on the side.
Not as. I'll get rid of the license. Like, hey kids, come get some candy in this nice black white van. Yeah. No. So I think, so prep education, I mean, I don't want to minimize the tremendous amount of work being done by a lot of our faculty in talking to primary care providers, talking to emergency rooms, talking to urgent care to educate them about PrEP and Narcan, all of those things, because they all intersect, they all live together. Yeah, it's great.
When it comes to these separate and stop taking the medication, what time that's usually the take to rebound?
The viral rebound that you're saying. So that's a good question. And it's very individualized. I would say I have people who stop taking their medicine and like a month later are like, my viral load is going to be sky high and it's still almost undetectable. And other people within 2 weeks, it's going up considerably. So, but I would say in sort of the bell curve population, it's usually within anywhere from like 3 to 6 weeks or so that you will see them kind of go back up again. And so, we're pretty, U equals U, undetectable equals untransmittable. And what I tell my patients living with HIV is, as long as you take your medicine every day, that will be true for you. What I tell the partners of people living with HIV is, I don't know what they're doing, And so one of the ways to protect yourself is PrEP is an option for you as well. But I have many couples in my clinic, who are serodifferent, positive, negative. They've gotten pregnant, had children, they're living normal, healthy lives completely. It's the ones that aren't coming through the door that are represented in that, 50% not retained in care, only barely 60% with viral suppression.
I think we're probably right on 1 o'clock. Let's give Dr. Rana one. Right.
Oh, great.
Stand all around.
I'm glad I tried to,
It was their natural communication.
I appreciate that. Oh.